All right, let's get started, everyone. It's so nice to see such a big group here today. I'm Courtney Valentine. I'm one of the co-chairs here for the Peds SIG. We're excited to have you all here. My other co-chair, Rachel, is unfortunately not well today, so she'll be home today. Hopefully, we will see her at our next visit. I wanted to start by reminding everybody to please put in the chat, your name and where you're from, so we can all get to know each other a little bit better if possible. We have a wonderful guest speaker today, Meghan Walls, who's going to be talking with us as a group. And then a couple other points. I think I want to just make sure that everyone has been getting the emails about the elections for Peds SIG. We have a co-chair, we have a secretary position open, and we are excited to have some great applications that we can all vote for. I didn't see a voting yet. I don't know if anyone else saw that yet, so I'm assuming that we're still waiting for more applications. Um, and hopefully we will know that soon because we typically start our new year in January. So that should be coming up soon. If anyone else has anything else they want to share in questions throughout, feel free to raise your hand, feel free to talk, feel free to put in the chat. We want this to be a great way to communicate with each other, and we all have different ways that we feel comfortable communicating. So whatever is easiest for you, you can also add in the closed captioning for Zoom if that's easiest. And if anyone has any job postings they'd like to put into the chat, that's also a nice way for us to connect. And those, I know we have some of our members who are in school and are looking for internships and postdocs. That's another great way to share different listings there. Anything else that anyone wanted to start with before we get to Meghan? Looking in the chat. Yay, lots of good postings. All right. Well, then let's give this over to Meghan if you'd like to get started and share.
Sure, I'm happy to. Thanks for having me. I see a couple familiar names that I've interacted with over the years. I'll start sharing in a second, but I just wanted to introduce myself. I'm Meghan Walls. I am a pediatric psychologist by trade. I work at Nemours Children's Health and have been at Nemours since I was a psychology fellow with some of these people on this phone who I think I've known since then. Before I share a little bit about pediatric health policy, which is what your co-chair has asked me to chat about. I obviously am a clinician by trade, but I've spent my past almost decade doing some mix of clinical and policy work. So when I was a fellow at Nemours, I spent 3 days a week in what is now a department that does not exist anymore, but it was a health and prevention arm of Nemours. It was before we really moved as much into policy. And so during my fellowship, I actually was able to do some what I'll call like little p policy work in the state of Delaware. And as I became an attending, and I'll talk about some of this, I was still pulled into the policy world a whole lot. So as all of you probably know, mental health policy is very high on the list of a lot of people right now, both in peds and adult world. And so our hospital has a policy and government affairs office in Delaware, but we also have an actual national office of policy. And so I started to become more and more involved sort of in that world. And about 2.5 years ago, I had a mentor who called me when our then director left government affairs and said, I think you really need to apply for this job. And I said, there's no way I'm qualified for that. And she said, I actually think you're most qualified for it. So, key message here already is pay attention to your mentors. They probably know what's good for you. So I applied to that job, and now I am the director of external affairs for Nemours Children's Health. So my job includes policy at the state level. We do have a national office that we partner with, and I'll talk about some of that. But I am over 4 states, so Delaware, Pennsylvania, Maryland, and New Jersey. And I also am over our community engagement team. So a lot of what I do in the policy world translates to what's happening in the community, how hospitals and healthcare systems invest in the community. So I sit over a couple $1 million investment team there as well, and we sort of merge these things all together. So it's a very interesting job. I still have a teeny tiny bit of clinical time. For those of you familiar with Nemours, we have a very large integrated primary care network, and our primary care network is where I started in fellowship. And there is a clinic in the city of Wilmington, Delaware that is very near and dear to my heart. And so when I took this more policy focused job about 2 years ago, my one request was that I could keep my clinical privileges and see my teen patients there, who I've been seeing some of them since they were little guys. And so I still do have a bit of clinical time, and, really it keeps me a little bit grounded, I think, to think about the policies that we need. So I'm going to share a little bit. I was not given like too much of what I had to talk about. So if I go rogue, or if we have other questions that, come in, please feel free to stop me. I hate when I'm presenting and can't see. So, Courtney, if someone like raises a hand while we're doing this, feel free to let me know. I'm happy to stop along the way.
Will do. I'll watch it.
Awesome. So I'm going to talk a little bit about a couple things, but the first thing I always start with is, this is sort of our Nemours statement that we talk about with public policy, and I think probably resonates with all of you, right? So our mission is to restore and improve the health of children. And I will say, since this was written, we have sort of added the piece to do this with a lens of health equity. My job is to make sure that we are thinking about that as we move through things. So I always, when I'm talking to clinical folks, I try to talk about why I think clinicians are actually really good at policy work, and to think about how you can get involved. So I always think about the fact that I think physicians, psychologists have sort of this eye for equity and inclusion and desire for level playing field. I think most of us would not be doing the work we do if that wasn't true. I also think you would be surprised what policymakers don't know, or maybe you wouldn't be if you watch the news, but they don't understand evidence-based solutions. And so I always talk about this with my my trainees, so like our residents and fellows, of, so much more than you think you know. So really thinking about that. But also, and I'm not going to read every line here, but just this general ability, I think, to navigate difficult situations and to get people to different places. And so I say that because I think talking to you about some of the pieces of policy we passed is nice, but I think thinking about how clinicians can sort of engage in this work is really important. So how do you do this work? And we'll talk a little bit more about this, but one of the things that I think is really helpful to me, or that has been helpful, is um, just remembering how educated and informed you are about your own expertise, and then becoming more educated and informed about what's happening policy wise. And again, I think, when I was a fellow, there was not like Twitter and some of these other things. So we didn't have the constant knowledge coming in or information coming in, but there's still a lot of easy ways to kind of find out what's happening. And I'll talk about some of those. But the other thing, and I will say this probably 5 times as I talk, is you just need to start to show up. So how do you do that can be really confusing and overwhelming. I have trainees and mentees all the time who ask me, I care about this thing. What do I do next? And so the thing that I say often is volunteer your time. And I don't mean go sign up for a volunteer shift, right? I mean, when your state professional association says, hey, is there anyone who wants to be on the advocacy committee? You say, all right, I don't really know what I'm doing, but I'm going to sign up. If there is a community advocacy group, so, let's say in your community, there is a group of families working on gun violence prevention, and you're like, I'm going to sign up. I'm going to find out what they're all about. Being involved at the community level is really the next step to the policy level. And so when I think about these pieces, I think it's really important. The other thing I'll say is, at the state level, this happens less as you move south in the country, but meetings are almost always public. So if you are someone who thinks, I'm just really curious what's going on, it can be super overwhelming, but you can actually watch your state government's public policy meetings. So it's really fun and riveting, but you can watch them talk about what's happening next. The example I'll give you is, during COVID, I kept showing up to Zoom meetings that they were talking about school reopenings. And I was just curious, mostly, honestly, because I had a kindergartner, and no one wants a kindergartner at home all the time during COVID. She was home, but I kept showing up to these meetings, and I got a call from the governor's office one day, and they said, do you want to co-chair the school reopening formal committee? And I said, not really, but I guess I was just voluntold. So I chaired this committee. But I only chaired that committee because the governor's policy officer kept seeing me sign into every single meeting. And afterwards, I would send a text and say, hey, our infectious disease docs say this, or hey, I heard someone in the meeting say this about mental health, and that's not really true in kids. So, I think sometimes it's just, you got to kind of put yourself out there. So I think it's important just to think about that. I always tell people that you have to sort of figure out how to open these walls for yourself to be involved. It does not take, necessarily chairing a SIG or a committee, but just being involved and really paying attention, whether that's state or federal level. I know many of you are psychologists or BHCs. Like I follow all of APA's um, advocacy and policy website. It's really easy. You can sign up. For example, Lisa Powell's on this call, like I follow Healthy Steps policy reports and briefs. So if there's things you're interested in, is it early childhood? Is it, you know, at Nemours, we have a gender wellness clinic. So we've talked a lot about what's going to happen with that with this new administration. Like you can find organizations that do the work and sign up to find out about them. AAP obviously has a really strong policy and advocacy arm. But then also, I read a lot of the introductions as I was, sitting here and you were all signing on. So many of you work for bigger healthcare systems. Your bigger healthcare systems have government affairs teams, and they often don't know you can be helpful unless you offer to. And so why I say that is I think there are some children's hospitals. We belong to Children's Hospital Association. We have government affairs meetings. So I know a lot of the colleagues in the children's hospitals and in the peds world. And some of them, like Nemours and some of my other colleagues like at CHOP, we all have a pretty open relationship with our clinicians, but not everyone does. So sometimes they're in those offices doing the work and they'll run it by you if it happens to affect your team. But if you are interested, you don't have to do this because we're all doing 100 things, but if you are interested, I really recommend finding out who the government affairs or government relations team is at your hospital and sending them an email like, hey, I'm interested. Can you keep me updated if there's bills on, I don't know what your thing might be, mental health, early childhood, whatever it is, and become that subject matter expert. So I got this current job is because they called me so much that eventually before I took this job, I said to the person who formerly had my job, you need to pay me or stop calling me because I was spending about 5 hours a week reviewing mental health legislation. And that's not great for your RVUs. So they ended up paying half my time before I actually shifted fully into the external affairs world. So really thinking about that. And then the other thing is sometimes there are non-government things that put you in good positions to talk policy. So like what do your state level committees look like just for other things? Are there boards or advocacy or advisory boards you could join? And so the example I'll give you here is in Delaware, we had a former lieutenant governor who decided that he was going to start a nonprofit, and it's called like Action for Delaware's Children. I think I got that right. And we heard about it, and we put a couple of our leaders from the hospital on that board. Just not me, not a policy person, just someone to sit and say, hey, in pediatrics, this is what we're doing, or in pediatrics, this is what we're thinking. And so we have a lot of those types of relationships. And I think we all know the value of relationships clinically. We all know how important it is to connect with our clients, our patients, our physician partners, our social workers. But I think we forget that the same thing is true outside. So when we have established these relationships, it can actually start to influence policy. And I always start talking about these things when I speak to clinicians because I think it's really overwhelming. And I think even for me, who I pretty much live and breathe government, I see a headline and it paralyzes me, or I read something and I get really worried, but I don't know what to do and I don't know where to go. And so sometimes it's kind of using these resources, your state psychological associations, your state AAP chapters, and finding out what are you doing? What are they doing? Can you be useful? And I find that while hospitals have to be a little bit more non-political, especially because we get government funding for so much, when you back into some of these state sort of advocacy or professional worlds, they actually are willing to take a little bit more risks sometimes. So you got to kind of figure out where you're most comfortable here. So I always tell people when I'm talking about this that I think the best way psychologists, physicians, mental health professionals can be good advocates is by using data. And I know that that's not popular to everyone, but what we have found is that when we are able to give policymakers, whether that is your mayor, your state senators, your congress people, data, and it makes sense, and you can walk them through something and tell them, how will this benefit the people who you serve? Not how does this benefit, me at the hospital, or how does this benefit a physician? How does this actually benefit our patients? And in peds, the upside of this is people tend to want to help kids, right? So they tend to be less political and want to help kids. So I put some examples on here because I think it's important to just think about. I remember when someone said to me, like, what is the problem you want to solve? And I was like, I don't know. Like, I'm a fellow. I don't have a problem to solve. But I realized that they, even the small things, right? Like, even the small things can be influenced by policy. And I think so often we forget that these things are very, very influenced by policy at the state level, at the federal level, but sometimes even lower than that. Sometimes within your organizations, what does your policy look like there? So some examples, we we've looked at this both at the state and federal level. I think it's no surprise to any of you that there's not enough mental health care workers. There's also not enough pediatric healthcare in general, especially in more rural areas. And so a lot of times we're able to do things like, hey, we really need you to expand loan repayment. And that has happened recently at both the federal and the state level. I live in Delaware, but I am over 4 states, and about, I think, 2 or 3, almost 3 of our states now have changed the way they do loan repayment for mental health. So many of you have probably applied for loan repayment, and we found in Delaware, the way that our rule was written was that physicians who worked in that clinic I talked about in Wilmington could get loan repayment through underserved populations, but mental health providers could not, because we had too many mental health providers. And as most of you know, physicians are boarded in their specialties. So if you're a pediatrician, that puts you in a certain category. But most psychologists and master's level folks don't have a board certification that goes along with it. And even when psychologists do, that's not how they look at the underserved, like what is an underserved area. So we changed this in Delaware, and it's not perfect, but it's improved. And so much of what we talk about is what is happening or in the world around us. Well, there's lots of chatter about not enough mental health care, parents can't get seen. Okay, well, if we're not doing loan repayment for our most needed workforce, what are we doing wrong here? And so we took that and worked with that. I'm not going to read through all of these, but I think a couple other ones that are interesting, like our trauma surgeons came to us and they said, hey, we have a higher rate of young kids being injured in car accidents. And we said, why? And they said, we don't know. And so we started looking into it. And we found that in one of our states, we were the only state who didn't have a law about rear-facing car seats until 2. And so we took this, and we actually took this to what they call like the Kids Caucus, so all the legislators who care about kids in the state. And we brought in multiple specialties. So we brought in our trauma team. We brought in our safety person who actually installs car seats at the hospital. We brought in our mental health team to talk about really just parenting in general and how we're not failing as parents if we're doing certain things wrong, because it's really easy for people to say, my kid was fine, so I'm not going to help you pass that law because then I look bad. And so we really have to think about, so much of policy is psychology, right? Like, how can we get people on the right page? And so we actually changed this law, and we now have a different law. The best part of that law to me actually is that in the law, it says that if you get pulled over for this, you're not going to fine or anything. They actually have to offer you a free car seat. So the state put in a fiscal note to this bill that says we are going to provide parents who cannot afford a car seat a car seat. It's not that expensive, right? A couple $1,000s a year for the state, but huge difference. And when we're talking about equity, it's really not fair for a parent who can't afford a car seat to be, perhaps given a fine or something versus those who can't. So we really are thinking about how we are using data to evoke change. And then the one other thing I put on here, which I just think is like, I want to point out, because I think that this is kind of low hanging fruit. One of our physicians came to us and said, we don't have a sickle cell registry that gives us the data we need to make sure that we know that families, when like a new treatment comes out, that we make sure they have access, or to know if a kid comes back into the hospital with a pain crisis that's not at our hospital, right? And so we said, okay, well, what could we do for you? What, like, is there a law we could pass? Is there something we could do? And they said, well, we really just need partnership with the Department of Public Health. And we said, sure. So we brought in DPH for a half a day and we fed them breakfast. And we had our physicians present to them. And we had our psychologist who does the pain management for the program present to them. And she also does a really cool thing, just which is close to motivational interviewing type work around that. And at the end of that, the legislator sitting in the room said, I'll do whatever you want me to do. And so we didn't pass a bill, but we did get this done. So we had a conversation with DPH. And I think that's important too, because as you're all thinking about like, I don't know if I need to pass a bill to change this thing in my clinic, you might not. You might just need to have the right partnership. So I think this was a neat one. Um, these are just other examples that I wanted to make sure I mentioned. You could Google all these federal level ones. These are huge, huge acts, but as a pediatric healthcare system, what we'll often do is like write letters of support or get patients to tell stories. The Integrated Care for Kids Act is actually a 2023 law that pushes more funding into kids who have Medicaid and CHIP coverage and who are getting integrated care. So shifts dollars to prevention, and makes reimbursement easier. And then there's things like the Kids Cope Act, which is a conglomerate of mental health things. And then the Trike Act, which is telehealth. So, we're watching at the federal level, we're writing letters of support, but often we're turning to our clinicians and saying, hey, give me some examples of how this helps so that we can give it to our congressional delegates and they can be able to talk about it. Or occasionally, honestly, we'll have families go down to DC and go to the Hill, and we have family days. As a healthcare system, once a year, we bring kids down there, and we have families tell our stories because it's really important. But at the state level, I think there's a couple things that we've done in our local states that I think are interesting and I think are more approachable, I'll say, when you're a clinician thinking about how these things work. I'm sure none of you really have time to, hang out in DC a few days a month, but probably you have time to figure out how to talk to your state legislators. I always tell clinicians, our state legislators work for us. They are your representatives. They have to answer your phone calls. They have to answer your emails, even if they don't want to. And eventually they will. And so sometimes it's just laying this groundwork like, hey, let us tell you about some things we're interested in or some things we're talking about. I highlighted this one given, the work that this group probably does and reading some of your intros. The behavioral health well visit is probably my most proud piece of policy work that we've done. I think some of you have probably heard about this, but Delaware was the first state to fully do this. So we actually in pre-COVID, I was chairing our lieutenant governor in the state of Delaware has behavioral health consortium. So everyone behavioral health in the state comes together. It's not great about talking about peds, as you can imagine, because often the focus gets put on like opioid use and those kinds of things. But we really brought it back to peds and we were able to shift everyone to talking about like true prevention. And one of the people who I co-chair the policy committee with, she is the executive director of a network in Delaware that is all like direct service folks. So think disability community providers and independent behavioral health providers for those communities. And we talked about the fact that so often kids and those individuals don't really have behavioral health diagnoses. So we're trying to do stuff preventively, but like there's nothing easy to bill. And yes, we know there's some prevention codes, but they're not great. And so we created a pretty hefty coalition with our local AP, with our Med Society, with our state psychological association, with our healthcare systems, and decided that there should be a behavioral health well visit, and that every year, just like you get a regular health visit, you should be able to bill for a behavioral health well visit. And then COVID happened, and so that slowed our progress. But I say this, I point to this one specifically because this is something where we had to give and take on this one. So our original ask was, and you can all imagine how well this went over, to be paid the exact same amount the physicians get paid for behavioral health well visits. And they were like, you can't bill for what a physician bills, because then what if you bill and the kid really needs a well visit? And I was like, well, fun fact, you're allowed to do 2 per year per all insurance now, but also I'm pretty sure you can all see who bills. You have a type of provider and you can figure it out. So we had to fight with our insurance commissioner and our insurance team, but we had a pretty strong coalition, and this now exists. I am happy to share. I meant to share beforehand, but Courtney, I failed, so I'll send to you. Highmark just put out their behavioral health well visit, like one pager of like what they will cover and what we should cover. And we worked with a coalition of mental health providers and physicians to create what this should look like at each developmental age. So there's an infant one, there's an early childhood one, there is an elementary school, a middle school, a adolescent, early adulthood, adulthood, late adulthood, and really easy for behavioral health providers to make sure they include what they need to get paid. We managed to stick those physician codes when we passed this bill. They still don't love them, but they are in there. And so this was one of those things that we took 4 years to get this done from start to finish, and we stuck with it. And I say that because I also think people think of policy in two ways. One is like, we're never getting anything done. Or two is like, oh, you run a bill and it gets passed and we watch the vote in the Senate and it's done. And none of these happen like that. So these are just some, I think, important examples of sort of where we are. The other thing that I just want to say here is sometimes it's also supporting legislation. So this insurance coverage for undocumented children, New Jersey passed that. Pennsylvania's working on it. Delaware's working on it. And our take on this really is just that all kids should have coverage. And so we really try to stay out of the politics of this, and we're working on the policy. Many of your hospitals see undocumented children, and you all take it as probably a Medicaid kind of write-off piece. But really important that even if we're not always leading the charge, that we're paying attention to these things, because we can't fix pediatric health if we are not paying attention to kids getting coverage. Our local state psychology board and not board, sorry, organization came out really strong opposing some anti-trans legislation that happened in a couple of our states. And so again, this isn't we're not always at the top, but I do think it's important to think about like, what are the big things, what are the small things, and how can we kind of work towards that? I kept this mostly short and sweet because I was told to, so we're gonna wrap up here, but I wanted to just say a couple of things, to close. One is that advocacy work certainly can be part of your job, and it doesn't have to be all of your job. I think that's the biggest overwhelming piece that often happens, is that we end up thinking we need to be able to do it all, and that's not true. I will also say here that if any of you are interested in this work and have questions, thoughts, want mentorship around it, I have quite a few folks that are not in my own hospital who I talk to regularly, who we talk about what are things we could do better. I recognize that APA and AAP have huge, huge advocacy teams, but sometimes it feels overwhelming to get involved with those. So just kind of thinking about your work as, we're advocating for our patients every day for different things. We're good at it. Pediatrics almost always tends to be more bipartisan. When we look at funding mechanisms that come from the feds, we often, end up saying, we're going to ask for this, we're going to ask for this. And people will say, well, the Democrats won't like that, the Republicans won't like that. But almost all of these bills that I mentioned before, like the Trike Act, the Kids Inc. Act, have major bipartisan support. Most of them have prime sponsors that are on both sides of the aisle. And while there is a lot to argue about in politics, kids often seem to be the thing that we can get people to wiggle on. And so I think that's really important as you think about, I admittedly sometimes get burnt out by trying to get things done in an environment that's more difficult, but I think that's really important. And not on this slide, but I think important too, is federal and state government are not the same thing. And so if you're in a state that feels really tough, think about what can I do outside of that state. But if you're looking at federal government processes and you're feeling stressed out by what's to come, our states still have a whole lot of control. And so really thinking about how you can affect things there. And the last thing I'll say, I started out with this, I'll start again. There is always room for experts. When we sit in rooms with policymakers, I often see like this slow kind of wheels turning of like, oh, we didn't realize that thing, or we didn't know this thing. And so part of our jobs, and I think probably most of you believe this, but part of our jobs is really to share our knowledge. I use the example of ACEs and trauma when I talk about this, because I think that we found a way, both in the psychology world, but also in the medical world, to put that information in the hands of the public, right? Most people now know what ACEs are. And so whenever we're having a hard time with something, whenever we're trying to figure it out, I always tell people when I'm talking to them, like, you are the expert. You know what this looks like. Your job is to get it in the hands of the public. And so how can we do that best? So, as you're thinking about what does pediatric health policy look like? Where can I be influential? I would argue that we probably are the most influential, but we need to think about what that looks like and how we do it. That's my email, if anyone wants to email me. But I'm going to stop sharing, and Courtney, I'll hand back to you.
First of all, thank you so much. That was just very inspiring, and obviously your passion for the work you do comes through, and it's I think going to help us to kind of have a great conversation about what does this look like for what we do. And I think a couple comments in the chat about being very excited to learn more about that one pager or the handout you have around behavioral health well visits. But I wanted to kind of open up to the group any questions that you have, any thoughts that kind of got you know, uh, interest peaked during her conversation.
A quick question. Thank you. This is really fascinating. Um, you mentioned that having relevant data that sort of tells a story can be really compelling and getting people to shift their views. I'm curious if you remember which data were most compelling for the behavioral health well visits to tell that story about why that's beneficial.
Yeah. So, I think as I sort of said, COVID happened in the middle of that, which we didn't want a global pandemic, but I think the focus on mental health during that time really kind of put a spotlight on, well, two things. I think one is just the increased mental health difficulties people were having, but second, we really got a lot of traction with parents and the public during that time of, oh, I wish my kid could just get checked out, because I don't know if this, pandemic has affected them. Like, is this normal? They're sitting in their room more? Is it not? And so some of the data was really around the COVID pandemic, but we also talked a lot about the cost of unaddressed mental health issues. So state government loves a good budget. We talked about the cost. I think it's $200 billion is what we lose in wages yearly on mental health issues that are untreated. 100 billion in healthcare costs. I mean, those are big numbers, but we actually took our state data too. So we looked at things like, how much dollars we were spending on things like inpatient care that could have been prevented. And it was tedious. We really had to do the work, but we mostly focused on like how the cost savings would work. While I would love to just say that we should do this because we should, which is how I feel, state government tends to really focus on that. The other thing we did talk about, and we use data, actually we use some Healthy Steps data, we use some, we have a trauma network in Delaware data, and really looking at unaddressed childhood trauma and how we're screening or not screening for that, and what that looks like longer term. So what does that look like, not just for lost wages, but what does that look like for substance use disorders, for incarceration, for these negative health behaviors? And that really seemed to be, those two seem to be it. So if you want to get state government to move, telling them they'll have a better workforce and more engaged adult audience, right? But also the cost is huge to them. So how are we preventing cost? And the other thing I'll just say about that, because I think it's important, is we spent, without exaggeration, probably 20 hours with the legislator who was the prime sponsor on this. I talked to her policy people. I talked to her. She would call me at 9 o'clock at night and be like, what do I say if they ask this question? And then we offered every time she had to have a conversation with someone else to go with her. So we did it was very time consuming, but I think sometimes it's not just giving people the information, it's being willing to actually be the carrier of the information, because they would mess those dollars up. They'd be like, well, we save money in mental health. I'm like, oh God, they're getting it wrong. So really being willing to not just share that data, but going with people and accompanying them to kind of help them understand that point.
That's awesome. Thank you. Did you guys publish the cost savings data that you found? I feel like psychologists are horrible about talking about money, but it's so useful.
Yeah, so we didn't on the state stuff because it was all estimated and it was like with our state OMB office. So really hard to get them to want to put that out there, honestly, because it's the state data. the cost savings for the other things are all public, right? So I mentioned we used Healthy Steps when we were looking at early childhood. We looked at like the CDC has a report on wages loss. So we didn't publish this particularly. And this bill, like it really was a work in progress. It just became effective this year. So we are actually now looking at, how do we get this? How do we perhaps do some presentations about it? We've kind of talked about in meetings like this, but we've not done anything formal because you don't want to jinx your bill when it hasn't passed yet. So we've talked about it here and there, but I think we probably will also put out in work. We have an insurer in Blue. So Highmark is one of our insurers in Delaware who actually was willing to work with us when we had this coming out. They were like, tell us about it, let our medical people review it. And so I will share they kind of have this Highmark one pager about it. But what I will say is like, they've said to us, hey, if you publish on this, call us because let's talk about what we should be saying and how we can help you and convince other payers to do this as well.
I'm looking here in the chat and it looks like Alex said that they were interested in more tips to get connected on the state level and trying to implement some of these policies.
Sure. So I think a couple things. One is one of the things I recommend doing, and it sounds so silly, but like is Googling if your state has either a mental health or a governor's advisory committee, like what do you have on mental health that already exist? Or if you're looking for a bigger healthcare picture, right? What does that look like? What are the committees that already exist? State government has to, even the more difficult state governments, they do have to list all of their committees that are public. So they will list them on their state websites. It's a little wonky, but figuring that out. But I think the number one thing that I recommend to people to get more connected is finding out who is your state local association, whether it's your state social work, psychology, whatever it might be. So we have, Delaware Psychological Association, Pennsylvania Psychological Association that we often ping, but also your local AAP chapters if you're working on peds work. So AAP, frankly, has been longer standing at this than APA at the national level, and AAP chapters in their states all have to have an advocacy agenda. So one of the examples is our AAP's top priority this year, or one of them, locally is working on HPV vaccine and uptake and working on actually, some of our states locally have implemented, you have to get HPV vaccines for school. So, thinking about that, I think is really important. And those people often know people at the state level. The other thing that I'll say is, it doesn't matter how big or small your state is. Delaware's small. And so I often say we have an easier time. We legitimately run into our state senators like in the gym. But your state reps, so not your Congress people who go to Washington and represent your state, but your state legislature, those people they limit the number of constituents each of those people can have. So you can go on your state website and say, there's almost every state has like a who's my legislator. And sometimes it's also reaching out to your direct legislator who represents you. And can you say like, hey, I am a PhD, a psychologist, a social worker, a physician, whatever I am, and I'm really interested in getting more involved in the state on some of these things. Like, what would you suggest? And a lot of times they'll actually say like, let's have coffee or let's talk about it. I have a couple of friends who have done this in other states. One's in New Hampshire, one's in Connecticut, but who have just reached out to their own legislators and said, I'm really interested, and have been put on either a committee or something. A lot of states also have open kind of calls for committees or for like advisory boards. And so sometimes you'll see, if you look on your state website, you can go to state boards and committees and they'll actually list what's open there. So I know a couple people who have just applied, like blindly applied because there's not, a psychologist on a board, and they can make headway that way.
Any other questions from the group?
I was going to say this has been super helpful. One of the things that like popped into my head is like the first thing that I could maybe do is you mentioned kind of checking with like your organization about advocacy boards and things like that. And I feel like that's like a small low hanging fruit that I might be able to like do first thing is just like see what advocacy options are within my organization and then branch out when, I have time. So I think that that's a good first step.
Yeah, and I think the other, as I was watching some of you type like where you're working with, I think people often think like, oh, only big hospitals have that. But like, most folks who work at community health centers or FQHCs, you actually have like a regional policy and advocacy crew. So even if, you know, it's not someone internal, I know like our Delaware, Maryland, Pennsylvania, our FQHCs have a lobbyist and they have an organization who works with them on policies. So even if you're not in a big hospital, a lot of times there's someone. It might not be right inside your organization sitting at a desk, but there are people who can help you kind of navigate and figure out the way.
That's amazing. Awesome. Thank you.
I know there's a couple people on the call, I think, who are in other states that have those behavioral well visits. And I wonder if maybe that could be a piece that we could communicate or find ways to connect with each other afterwards as well, to kind of boots on the ground, like who's doing it, how's it going? I know Chus, you shared that before, but it's just, I think sometimes we are in different states that don't have it. And so we think this is magical, but it's happening in lots of places. And if we can connect and figure out how to advocate in our own places, but also recognize how that's working in different places.
Yeah. Hi, Courtney and team, and hi, Megan. This was great. Yes, we we did a community conversation a year and a half ago or something like that, with a few people in different states that had either launched it or were in the process of getting this visit. And you know, hearing Megan talk about this made me wonder if we could revisit at some point and putting everyone together again and just talk about any advancements for this. All the states have slightly different either codes or requirements for the visit. And yeah, it would be, you know, I think it would be valuable to go back and look at those again, and you know, how to help people who are starting to think about it. So yeah, thanks for bringing it up.
I'm curious to know if there's anybody else who's part of advocacy within their organization or their states that they want to share about, or like something that we haven't already mentioned that they know about that maybe could be relevant to us as well.
I can speak for a minute about that. So some of it's overlap to what Chus just said, because I work in Massachusetts as well. And we have focused a lot on the annual wellness exam. The other thing that I think we're getting some good traction in lots of different states that I wonder if would be useful for people too is around the preventive benefits. So having access to behavioral health services without a formal diagnosis. So more in the prevention and promotion space, where maybe there's a little bit of a pink flag, as we like to call them, or you know, some states like California have been really progressive in that, and for social determinants of health also as a qualifier for access to behavioral health. So I think there's some good traction in many different states about preventive behavioral health.
That's wonderful. Thank you.
Dr. Walls, it's always great to hear from you and about your work. I've been meaning to reach out to you because we have advocated to get Ohio Department of Insurance as their two priorities for next year to think about behavioral health well visits and moving that forward. So I'd love to pick your brain and everybody else's on it. One thing that continues to come up is like whether or not those should only be allowed to be done in primary care, if any community mental health agency can do it, and can schools do it? And if so, how do we keep track of it? Because if you're a school who gets reimbursed for it, why wouldn't you just run all the kids through it and make a bunch of money? But then how do we know if it's been done? And I'm just curious how other people handled those kinds of things.
That was our biggest fight, I think, that we had on this bill, especially with our insurance folks. I will say though, and hopefully no one from the insurance industry is on here. It's an excuse, right? Like it's laziness. They don't want to actually track it. They can see the kind of provider. They can see if you're a school provider. They can see if you're in primary care. They can see if it came from Nemours. They can see if they came from Cincinnati or whatever, right? So that's part of it. But we actually pulled in our state social work, and we have like a master's level group of providers too. And we set a bar, like you had to have XYZ qualification, and you had to do, you know, whatever thing. And DPA in Delaware is actually currently working on like a CE course for this so that we can actually train people in it. But the way we dealt with it was by actually putting in requirements that kind of held people to certain levels. Most of the community behavioral health people were interested in doing this, but some of them came to us and said, like, this isn't my thing, right? I don't want someone to come to me and ask for it and I can't provide it. And so it actually worked both ways. So we kind of appeased the insurance folks by saying you have to have whatever it was. I could pull it, Cody, and I can email you. But it was definitely insurance with a conversation with our insurance commissioner and the master's level folks who were in the community, and a couple of private psychologists who are interested in doing this in the community. But really, like, what is the level of training, and then what would you have to do to be able to do these? And that seemed to kind of unruffle feathers, I think, on both ends of it.
That's super helpful. Yeah, my other worry is that this is just going to turn into another specialty mental health kind of visit that won't be feasible in primary care anymore, and trying to make sure that we advocate that it's a reasonable bite-sized chunk that we could accomplish within, like, you know, within an integrated model.
Yeah, to be fair, I'm still not 100% convinced that this is like going to go off without a hitch, because they just added it. Everyone just added it to their plans, and you can bill, and there's a one pager, and you can do all those things. But what does that look like? My guess is that now that we had to like clean up the bill this last session, but as of July, it's really finished. So I think I'll have more lessons to share as we move forward. But I think setting up like what level of training do you have to do this, but then also B is like, how do you have to get trained on doing it? Because we did put out clinical guidelines for it too.
That's awesome. Yeah, it's great to hear. And this
I'm happy to
came...
share that with this crew. There's like, you know, no trademark on it, but don't steal it from us without asking. But like, I'm happy to send, we actually have an entire like clinical pathway for it. And each developmental stage has questions and what screeners you have to do and all of those things to get actually reimbursed.
That's amazing. That would be super helpful. Thanks. And this just came up because, you know, we had 3 to 4 things that was just driving us crazy in our model. And so I asked to meet with government relations, and I put together a one-pager for him that our governor, Mike DeWine, is really big on the grandma's test, that if you can't explain this to your grandmother at the kitchen table and have her say that makes perfect sense, then it's not good legislation. And so everything that goes to DeWine has to pass the grandma's test. So I kind of created a one-pager that does that. You know, here's the problem, here's why it's a problem, here are a couple facts, and here's like how it could be changed or whatever. So I just gave that to him on the 4 things that was really 3 to 4 things that was driving us crazy. I emailed it to him. He said, this is really interesting. Can I meet with you? We had a went over it, and it just so happened a month later, Ohio Department of Insurance reached out, and Governor DeWine's reached out and said, does anybody have insight into why there's such a huge mental health access problem in Ohio? And he's like, actually, I have 4 points that is well spelled out and that I can repeat, just like a month after that. And that's how this whole thing happened. So sometimes just arming your government relations folks in kind of simple terms, what they can do and share and make it, I mean, you can talk about these things in a way in which it's infuriating, right? Like, so like same day access, like you still in many places can't bill on the same day if you're employed by the primary care organization, right? So, you know, equipping them to say, we live in a situation where we're in the middle of a mental health crisis and an access crisis, yet I have to wave to patients as they walk out, and then the parents have to take another day off work, and the kid has to take another day off school to come in on another day for me to do that same visit because we can't bill the same day. Does that make any sense to anybody? And, you know, people get upset about that, and they're like, that's more time off work, that's more time off school, we have a school absentee problem, and we're actually driving it for no real reason. And, you know, stuff like that, just like little scripts like that, I think made a really big difference for him. And now he loves us. He comes to us all the time for these things because we give him like exactly what to say, and it has to pass the grandma's test. So that's just a little tip that got this whole thing started for us.
Our joke, Cody, is that our governor, who just finished, we like talk to him like he's the grandma. So our joke is if the governor can understand it. I don't think you can call it the governor's test. That doesn't sound very nice, but we would always be like, if we can give this to Governor Carney in 4 points and he gets it, like, we're good.
I love that though, because I think so often when we think about being the expert, we feel like we have to have all of this stuff to make it really sophisticated and, really polished. And that's the opposite of, I think, how, we need to be doing things to really get our points across. So what a great way, Cody, of just kind of leaning into the things that were hard and making it really accessible. And I just think I think about even my own organization and, thinking about how do we do this within the organization and within our communities, and how do we kind of move forward in some of these advocacy ways. And it's just such great insight for today. So thank you guys. I think people are heading out soon. I just wanted to thank you all so much for coming today. Thanks for the conversation. And thank you, Dr. Walls, so much for this inspiring presentation. I want to remind everybody to look for the elections for our Peds SIG, and look for our topic for next month. We also are floating around some ideas for some work groups that might be kind of aligned with or sponsored by our Peds SIG, one about early childhood health and some of the advocacy pieces that we've been talking about today, and then some other interest in school-based integrated care. And so if anyone has any interest in those areas, wants to participate, lead, anything along that way, please feel free to reach out to myself or to anyone else on the Peds SIG. And I'll put my email address in here. Any last questions or comments that people want to share? Well, thank you, everybody. And then we will, when we get some of those information that I think Dr. Walls is going to send to me, I will make sure to put that on Basecamp so that everyone can have access to it. And if you can't have access to Basecamp, then email me and we will make sure to figure out how to get everybody connected. And then, yeah, have a wonderful rest of your Monday, everyone. Thank you so much.